Hello, my name is Professor Cruzet. I'm a urologist and my main research interest is in focal treatment of prostate cancer with HIFU. Let's look about prostate cancer worldwide. With the screening, the mortality of prostate cancer has decreased during the last years. But at what cost for individual patients? The prostate cancer in France, the incidence is 58,000 patients a year and 68,000 patients a year in Germany. This is the first most common cancer for men. And in France, 8,000 patients died every year from prostate cancer. This is one patient every hour. And in Germany, it's 12,000 patients a year. 80% of those patients are diagnosed with an early stage and can be cured. But we still have overtreatment, and that leads to side effects. When we look at the management of prostate cancer, according to the stage, for the low-risk prostate cancer, most of the time, we are performing active surveillance. For the intermediate-risk prostate cancer, we are performing local treatment such as surgery, radiation therapy, brachytherapy, or HIFU. For the high-risk prostate cancer, we need to apply aggressive treatment such as surgery plus radiation or radiation plus hormone. What could be the place for focal therapy? When we look at all the patients diagnosed with prostate cancer who deserve a local treatment, 75% of the patient has multifocal tumors and need a total treatment. But for 25% of those tumors, probably 9,000 patients a year in France, we have only one foci or one aggressive tumor. And we can perform a focal treatment by destroying the cancer and preserving the normal prostate around. This strategy can treat the cancer and bring less side effect and less morbidity. High-intensity focused ultrasound is like using a glass magnifier with lights. But we are not using lights, we're using ultrasound, and by focusing the ultrasound in one spot, we generate heat. And by increasing the power 10,000 times more than the imaging ultrasound, we can generate enough heat to destroy tissue. For example, in this movie, the focal point is localized in the water and is boiling water, generating steam. In the biological tissue, the addition of elementary lesion can destroy a volume and will bring necrosis, coagulation necrosis inside this tissue. The probe used today is a dynamic focusing probe. It is made by 16 isocentric rings with equal surface, and by electronic displacement of the focal point, we can have 8 different focal points within the tissue. The maximum depth we can reach is 40 millimeters, and every HIFU shot is 5 millimeters long by 1.7 millimeters large. The advantages of HIFU: this is a scarless procedure performed transrectally. It is MRI and ultrasound guided. We have a direct control of the treatment efficacy with contrast-enhanced ultrasound, and we can retreat immediately if the treatment is not sufficient. It is a conformational treatment that can bring focal treatment. It can be repeated if needed, and it does not cut bridges for standard treatments. In the large European HIFU series published, we also find a 10 years oncological survival rates from 92% up to 100%. The treatment of prostate cancer brings morbidity to the patients. Even active surveillance with the aging of the patient brings some kind of incontinence and a little bit of erectile dysfunction. Radical radiotherapy or radical prostatectomy, of course, have significant side effects such as incontinence and impotence. Focal treatment with HIFU can be an answer to those side effects by treating the cancer while decreasing dramatically the side effects. Let's look at the results of whole gland HIFU. Whole gland HIFU, we have results for more than 2,000 patients treated till 97 that validate HIFU efficacy for prostate cancer treatment. The oncological results seem similar to those obtained with external radiotherapy or IMRT. Je la refais. Whole gland HIFU. With whole gland HIFU, we have results from more than 2,000 patients treated till 97 that validated the HIFU efficacy for prostate cancer treatment. Those oncological results are similar to those obtained with external radiotherapy or IMRT. We have 3 published articles with long-term results of 2,244 patients treated in the 3 historical centers in Europe. The inclusion criteria between those studies were similar: localized prostate cancer, PSA lower than 30, no previous treatments, and 3 generations of device used: the prototype from 97 to 99, the ablator Maxis for 2000 to 2004, and the integrated imaging 2005-2008. The follow-up was over 8 years in all the studies. The biochemical results obtained with HIFU was good. The median PSA was between 0.07 and 0.14 nanogram per ml. And you can see the PSA before treatment dropping after treatment. The biochemical disease-free rate at 10 years was close to 70% for the low-risk prostate cancer. This is the upper curve. 65% for the intermediate-risk prostate cancer. Here it's the blue one. And 50% for the high-risk prostate cancer, the red curves in the different European centers. The 10 years cancer-specific survival rates was between 97 to 99%, and the metastasis-free survival rates was from 94 to 95%. The salvage treatment-free rates at 10 years was 98% for the low-risk patient, 72% for the intermediate-risk patient, and 68% for the high-risk patient. With those good results in this historical series, we try to be more precise, and now the aim is to develop focal treatment. Focal treatment, the aim are to precisely diagnose and localize the cancer within the prostate, is to treat the identified cancer and preserving the normal prostate. That will lead to preserve the erectile and urinary function, but without compromising the survival. The idea is to remove the bad part of the prostate to keep the good one. The first step is to localize the cancer, and the best tool is the MRI. The radiologist will control the different suspicious area within the prostate, and that will help the targeting biopsy. With this MRI, we're going to bring this MRI and fuse it with a 3D truss MRI fusion system. The idea is to localize within the MRI image the suspicious foci and do targeting biopsy inside those suspicious foci. When we get the diagnosis of cancer, the patient is brought to the operative table. We bring the Focal One HIFU device to the patient. It's composed by a transrectal ultrasound probe and 2 control screens to planify and perform the treatment. The first step is to bring the MRI and to fuse it with the live ultrasound image of the patient's prostate. We get the ultrasound prostate here. We bring the MRI with the suspicious foci inside, and by an elastic fusion, we fuse those two images into a volume with the target inside. In video, we can see clearly here in this yellow area the two tumors located inside the prostate. All the rest of the prostate does not have cancer and can be spared. We can also use the MRI 3D biopsy mapping. The idea is to bring the 3D volume with all the trajectory of the biopsy and the positive biopsy plus target, and fuse this by, again, an elastic fusion to have this fusion 3D model. This is another example of anterior tumor, and only the targeted biopsy are positive, and we can clearly treat this area while preserving the rest of the prostate. When the fusion is performed, we have to control the quality of this fusion. We have two tools for that. The first one is the Hausdorff distance that show you with a color scale the deformation applied to the MRI or the 3D mapping biopsy. And we can correct it if the fusion is not correct. The other tools is this DICE index that show you the coefficient of deformation of each volume. When the fusion is good, the control is satisfying, we can move to the treatment. Surgeon has planned his treatment, and you can see all the different HIFU shots. All these points are HIFU shots within the prostate. We can see clearly cavitation inside the prostate that show efficacy of necrosis. At any time, the surgeon can adjust and add or remove some HIFU shots in order to cover nicely the target area. When the treatment is complete, we need to control the quality of necrosis. For that, we use contrast-enhanced ultrasound microbubbles, and we can clearly see on those images the B-mode ultrasound of the prostate with all the prostate shape, and the same image with contrast, and we can clearly see the necrosis in the right part of the prostate. If this treatment is not sufficient, we can immediately retreat and complete the treatment. For example, here we can see the cancer foci with the positive biopsy within the necrosis, but on the side you can see that there is remaining viable tissue, and we need to retreat to complete the necrosis around this tumor. The final control will be performed by MRI and targeted biopsy. This is an early MRI just after the treatment, and we can see the same image than we have on the contrast-enhanced ultrasound, the necrosis in the right part of the prostate. In conclusion, HIFU is a very promising treatment for prostate cancer, and especially for focal treatment. This is a transrectal treatment. There is no scar for the patient. The indications are localized prostate cancer with no risk of lymph node involvement. This treatment can be repeated if needed. It does not cut bridges for standard treatments such as surgery or radiation therapy, and it's also very useful as a salvage treatment for recurrence after surgery or radiation therapy or even brachytherapy. Thank you for your attention.